Well, it's my pleasure to be here, and thank you all for having me join your academic half day. So what I want to talk about in this next hour, or in the next 50 minutes, I should say, is that I'd like us to basically, my goals for the session are that we can work towards a place where all of you will be able to state the elements of the PICO question framework and understand its utility for helping you to not generate, but really clarify clinical questions, that you'll be able to utilize various information resources to find answers to clinical questions. And importantly, that you'll be able to differentiate between the available information resources to determine which resource or resources are the most appropriate given a question or an information need or a circumstance. So I think that last part is crucial because, just throwing a bunch of resources at you and saying, you could use Dynamed, or you could use UpToDate, or you could use Cochrane library is good. It's a first step, but the real key is being able to start to differentiate of sort of why am I asking this question? Why do I need this information? And consequently, what might be the most helpful resource or resources to answer this question? To take a little bit of a step back and just broaden out and look at the evidence-based medicine cycle as a whole. As I'm hearing, this talk is part of a series. Hopefully some of this information will be familiar and will ring bells. Sort of classic definition of evidence-based medicine is that it's the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. And the information cycle will begin anytime an information need arises. And as I'm sure I don't have to tell you all, this happens all the time. There have been studies showing that it can happen as often as 6 to 8 times an hour on an average day of clinical practice. So these information needs are coming up all the time. Not all of them are you going to sort of engage to the extent that we're going to be talking about today when we're looking at, PICO questions and rigorous evidence searching. Sometimes you just need a background information source, or it's a quick lookup about dosing or something of that nature. But there are going to be those occasions where you really do need to dig deeper, and that's primarily what we're going to be talking about today. So when you have that question, you want to stop and really take a moment to think about it, and that's what the PICO format is helpful for, and we'll talk more about that. The next step, of course, is going to be your search. Where are you going to go to find information to answer your question? The appraisal step is, I'll be honest, rarely necessary. I say rarely in the sense that, maybe only a handful out of every 100 clinical questions will you necessarily need to go to the step of, rigorously, critically appraising and evaluating the risk of bias in an individual study. There are occasions, and we'll talk very briefly about it, but very often, because there are great tools available, you can fall back on others' analysis and assessment of the risk of bias or of the validity of the study. So we'll talk about pre-appraised resources that will help you use those kinds of shortcuts when appropriate. And then, of course, the last step is making a determination in conjunction with the patient, their preferences, and all of the things that make them unique, their age, their comorbidity, their family history, their social history, and all of those things to determine, can I use this evidence that I found to really improve this patient's care? So I should say the classic PICO format is just that. It's the P, the I, the C, and the O. But I'm going to talk today about the PICOT format with the 2 T's stuck on there because I think it's very helpful for bridging the ask and acquire step. So if you have seen this before, it'll be a quick review. And if this is new to you, then hopefully it will be a helpful introduction to the PICO format. PICO can be used for clinical questions. It can be used for clinically oriented research questions. And in, higher quality literature and literature that's sort of well designed, very often the authors will actually state their PICO question. They might not say PICO question, but they will clearly state their research question, and you can sort of discern or pick out the PICO elements of that question if it's a well-formulated clinical question. So P stands for patient or population, and I think that that's what's really essential to the first element of the PICO question, is thinking about your patient as a member of a reasonable clinical study population. So on occasions where, you know, I've had opportunities to teach PICO to people in a little bit of more of like a workshop-y format, and people are generating their own PICO questions. Very often, if we're working on a, you know, a case vignette or something like that, and the patient in the case vignette is a 57-year-old woman, you know, the student or the resident or whoever the learner is will say, oh, the P is, you know, 57-year-old woman or 57-year-old women. And that's certainly true of the patient in the vignette, or, you know, the patient who might be in front of you. But the goal of the PICO is to help you get to applicable literature. And so starting to think about your patient as a member of a reasonable clinical study population. So there is no clinical researcher out there who is recruiting for a study a population of exclusively 57-year-old women. You know what I mean? Depending on what their research question is, the nature of their research question, it could be women, it could be menopausal women, it could be adults. So starting to think about, you know, my patient would be a member of what sort of reasonable to recruit clinical study population that's still going to be applicable for my purposes is so that's why I think it's kind of helpful in this step to start to abstract out your patient's characteristics and think about them as a member of what would be a reasonable clinical study population. I is the intervention or the exposure of interest. So the exposure, of course, could be some kind of harmful exposure, like to a chemical or a drug that may have had an adverse reaction. Exposure could also be a disease, right? So if your PICO question is something like, you know, do women who have had pelvic inflammatory disease, are they at higher risk for cervical cancer? In that case, our exposure of interest is pelvic inflammatory disease. So starting to think about your eye, you know, very often it will be a traditional sort of intervention like a drug or a surgical procedure, but it could be anything. It could be medical advice. It could be providing patient education information in their native language. That could be an intervention. Or again, it can be an exposure. So being sort of flexible in our thinking there is very helpful, especially once we get outside of strictly therapy questions. C is the comparison or control, and that's almost always going to be sort of whatever is the current standard of care. In older studies, it would be versus placebo, and sometimes you'll still see that, but more often you'll see whatever's the current standard of care, because usually we're not deciding like, should I do something or nothing for this patient? It's should I do this new or alternative thing, or should I do the standard of care? And O are the outcomes of interest. And the reason why this is so important to have these things really, to have your outcomes really clearly locked down in your mind. And we'll see an example of this today. But the reason why it can be so important is because there is just so much literature out there. There's over 800,000 citations being added to PubMed every single year. And so if you don't go into the literature with a really clear idea of what patient-focused outcomes are important to you in answering the question, you may find that you get, you know, you've wasted or invested more time in a particular result than you actually needed to, because once you investigate a little more closely, you're like, well, I don't really care about, you know, sort of length of stay, for example. I really care about adverse events or whatever it might be. And there's just so much literature out there. It can be easy to kind of go down that wrong path if you don't have your PICO question clarified. And the two T's that we're going to talk about that I'll add on as a sort of a coda here. And the PICOT model with the two T's on the end was pioneered at Duke University Medical Center, which is really sort of like a champion institution for evidence-based practice, are type of question. So what type of question do I have? And consequently, or in a very related way, what type of study do I have? So if I have a therapy question, ideally what I would love to find is a randomized controlled trial or a systematic review of randomized controlled trials, whereas if I have a prognosis question or an etiology question, I may instead be looking for a cohort study. As you know, especially with an etiology question, we're never going to have a randomized study that exposes one group to a harmful exposure. And so the best available evidence we could hope for would be some type of observational study. So that's why I think it can be helpful. Certainly the PICO, just the straight old PICO, is useful. And in cases where you do need to find an original study as opposed to just an answer to your question, you might also want to think about, what type of question is this? And consequently, what type of study do I hope might be available to answer my question, to get that clarified before you dig into the literature. So in order to look at the various resources I want to share with you today and sort of load up your toolkit in answering clinical questions, we're going to look at a couple of different resources, all with the same question, because it will help us compare and contrast these resources more easily. And the question is it safe to discharge patients with PE home on oral anticoagulants as opposed to admitting them? Or is it safe to discharge them early, as a sort of related, if not synonymous question? So this question came to us courtesy of an emergency medicine resident who is having a hard time finding evidence to answer the question. And when I dug in with him a little bit more, it turned out that actually the reason he was having a hard time was kind of PICO related. And so I want to take a moment with all of you to walk through the question that we really need to answer. So if anybody wants to volunteer, either you're welcome to unmute yourself or in the chat. Who is the patient population of interest here?
So Lanice is saying patients with PE.
Yeah, exactly. That's 100% correct. It's patients with PE. And now, not intentionally meant to be tricky, but the sort of trickier aspect of this question is, what's the intervention we're interested in?
So Tom is saying discharge versus admission.
Yeah, exactly. So yeah, I'm seeing a lot of discharge versus admission, a little bit of oral anticoagulation, and the crux of the question absolutely is, outpatient treatment versus inpatient treatment, or like early discharge versus not. And the problem that this resident was having as he was going into the literature is he was searching using terms like PE oral anticoagulant or PE oral anticoagulation, and was getting a whole lot of results, or sort of getting lost in the weeds of choice of anticoagulant, as opposed to, treatment setting, right? Which is really what the person was interested in. And so I like to share this question. I think it's a great example of the way in which if you, it's a couple of different things. Number one, like stopping to clarify the question can be really helpful. And number two, stopping to clarify the question will help you bridge that next step. Because when we went from searching pulmonary embolism oral anticoagulant to pulmonary embolism outpatient, we started immediately getting much better results, and the results really that he was looking for. And so just to round this out, what would be, one or more examples of the kind of patient-focused outcomes we would care about here? Safety, mortality, absolutely. And so, yeah, I had, mortality, recurrence, risk of major bleed or other adverse events. And those are all, of course, great examples of the kind of patient-focused outcomes we want to make sure that we are finding literature to answer, as opposed to the sort of system level outcomes, which will I don't want to say clog up the literature, but just like we are not the, they're not for what we're looking for in this kind of case. So thank you all for your participation in the chat. And now that we've got our sort of revised PICO question, which is among patients with PE, is outpatient treatment as safe and effective as inpatient treatment, we are going to take it to the literature. And the first resource I want to look at with you all is Dynamed. So as I'm opening up Dynamed, I'm interested to hear if anybody wants to say any experiences they've had with Dynamed, positive, negative, or otherwise. And you'll see that Dynamed is right here on the library homepage under our popular tools menu. If you ever needed to find it somehow in another way, you could search for it on our databases list, but we do try to make it easily accessible. If you're off campus, when you go to access Dynamed, you'd be prompted to log in with your Mount Sinai network ID and password. And if you're on campus, you'll be able to access it seamlessly. I see great comment, great resource for evidence-based medicine. I agree and certainly welcome any other thoughts folks might have about that, or if you want to expand on that at all. So I am going to run my search for PE outpatient. And one of the things I always find a little bit weird about Dynamed is I feel like they cannot quite fine-tune their search results algorithm. Like I feel like they never have quite nailed it. And so it's always the case for me that the result I want is never the top result, but it's like a few results down. And that is very much true in this example. So I see in the management, in the entry on pulmonary embolism treatment, I can jump right to that section on outpatient management for low risk stable patients. And there's a lot of editorial standardization in Dynamed. So you'll see all of the management entries will be really fairly uniform. And you can see in this entry, which is a good example, most of them will start out with recommendations from professional organizations. So information that's been extracted from guidelines typically. And they'll include the grade of the evidence as graded by that, or, in this case, the British Thoracic Society has given this a grade D. So you would need to, if you wanted to know a little bit more about what that meant, you'd need to read up on that. But the particular element of Dynamed that I find really, really useful, and as somebody else had said, like very good, makes it a very good EBM resource, is the evidence for section. So in the evidence for section, they have what they call study summaries. I call them headlines. And so our first headline here is implementation of integrated electronic clinical decision support system for risk stratification might increase outpatient management without increasing return visits to the hospital within 5 days. So do we care about this? Why or why not? Okay, so I've got one person suggesting we care because of one of our outcomes. That's a good hypothesis of recurrence. Any other thoughts in favor or against about if we want to engage further with this content? So can we, as individual clinicians, implement an integrated electronic clinical decision support system? Yeah, so I see one person saying like it's not the same intervention. It's not the same intervention, and it's not really something that we can affect as individuals. And the real outcome here is, one of the important outcomes is return hospital visits within 5 days. So I mean, I guess returning to the hospital would be, something a patient would care about. But so maybe it's more accurate to say that, the reason why we might scroll past this one is because we as clinicians, don't have the ability to implement this change or implement this intervention, so to speak. So I'm going to scroll down here. Our next study summary or headline is outpatient treatment with discharge within 24 hours appears to reduce hospitalization without increasing adverse events compared to inpatient treatment in low risk patients with acute symptomatic PE. Do we care or we don't care? You can just nod or shake your head or give me the thumbs up. Yeah, I would say this, matches our PICO question pretty well. And so now we can dig in a little bit more to the information that Dynamed is providing. So we see, here's our study summary, which again, I like to call the headline. And this headline is supported by 2 randomized trials. So we know what types of studies are available to answer the question. And if we drop down the details, we're going to find out that these are 2 RCTs that have methodological limitations. And then we're going to get more information on each of these trials. So the first one was a randomized trial with possible selection bias. If I read on a little bit more, I'll see patients could be excluded from enrollment on the basis of physician's expectation of noncompliance or other discomfort to enroll. And that is, where that possible selection bias crept in there because there was so much sort of room for enrollment or non-enrollment based on the physician's discretion. We see how this study defined low risk. So that's pertinent to us as well in terms of could we actually apply the evidence from the study to our patient. And then we're going to get information on the intervention, on the 30-day primary outcome, and outcome versus treatment groups for all of the outcomes. So duration of hospitalization, serious adverse event, any adverse event, bleeding related hospitalizations or return visits. And you can see here that we're getting our p-values or being told this actually was not statistically significant. In the case of any adverse event, they're also reporting that the number needed to harm. So no statistical difference, quite close there for any serious adverse events. But the number needed to harm for any adverse event, not necessarily a major adverse event, is relatively low. So something to take into account as we're thinking about our patients' values and preferences there. And we're going to get this same kind of information and assessment of the study, which I wouldn't characterize as like a really rigorous critical appraisal, but just sort of methodological highlights and lowlights, as well as, again, the sort of EBM numeracy information we need, number needed to harm, number needed to treat, those kinds of information. And I also think it's really helpful. Dynamed recently started adding no additional, whether there's a Cochrane review on the topic. And in this case, they say there are no additional trials found in a Cochrane review. So we now know that there are 2 RCTs, one from 2018, one from 2011, as well as a 2019 Cochrane review, all of which support our study headline. So that's the kind of information you can expect to find in Dynamed. And now I want to compare and contrast with the kind of information that UpToDate is going to present us on this same question. I see a question in the chat, and it's is every search result in Dynamed an individual article? So the answer there is no, but they are grouped. So let me go back to the search results page. So these sort of sublinks these are subsections of this one prevention related article on VTE prophylaxis. Same thing here, what we're seeing, outpatient management and risk stratification. These are subsections of the PE treatment entry. So if you see these sort of indented hyperlinks, they're pointing you to specific subsections within the entry that might be particularly relevant based on your search terms. But here, where it says like condition PE, that's just one entry with no subsections highlighted. So over here, I'm now over here in UpToDate, and I'm going to search that same thing, PE outpatient. And in contrast, UpToDate, I think, has like kind of really nailed it. It's one of the things that makes UpToDate, I think, very, very useful resource, is that almost always I do find that, you know, the top entry or the top link I'm being served is the one that I want to answer my question. So I can see they're suggesting that I go to the anticoagulation section within the treatment, prognosis, and follow-up of acute PE. And I'm going to jump right there. And even though the name of the section they're linking me to doesn't seem terribly relevant, once I get there, I can see that there's sort of a subsection. Maybe they just don't link in the results to the subsections, but there is a subsection on oral anticoagulation. And you can see immediately that the type of information, the way the information is being presented to me and UpToDate, is pretty different. So here we get in select patients with PE, outpatient therapy can be administered, giving the first dose in the hospital or urgent care with the remaining doses given at home. The decision should be made in the context of the patient's condition for understanding risk benefit and their preferences. So this is, I also love this question. It's a really great example of where patient preferences can come strongly into play. They go on to say, although the ideal candidate is poorly defined, guideline groups, RCTs, and meta-analysis suggest that in patients with PE, outpatient anticoagulation is safe and effective in carefully selected patients with all of the following features. So it's just like I, as a clinician, can start to kind of run through this. And if I see like, oh, you know what, they actually do have liver failure, or, you know, they have a serious comorbid condition, I know immediately, like, I don't really need to read on about the evidence to support this decision, because my patient probably wouldn't be a good candidate. So they are both addressing this question of, you know, PE outpatient, but in pretty different ways. You'll see if I scroll down a little bit, this particular UpToDate entry, or this section, I should say, of this UpToDate entry has actually, you know, does give us a not insubstantial rundown of the evidence. And you can see here they're talking about one RCT with 344 patients. They're talking about a 2013 meta-analysis. Then they're talking about a cohort study and then another RCT. So whereas in Dynamed, the way that the information is arranged, and I'll just jump back there for a second to emphasize this point. You know, we looked at this headline that's got some RCTs, and then they go on to, you know, add other studies that also address this question or similar questions, but that are sort of lower down on the EBM pyramid, the evidence hierarchy. So we've got a range of like RCTs, cohort studies, we have an uncontrolled trial here, and so on and so forth. Also within Dynamed, we've got our 2018 trial, our most recent trial, listed on top, followed by our 2011 trial. And as you saw, they also here talk very briefly or acknowledge the existence of a 2019 Cochrane review. Whereas in UpToDate, there's a couple of things that are different. Number one, it doesn't seem to necessarily be arranged as far as I can tell, or as far as, you know, the reader can tell at a glance. It's not necessarily arranged either chronologically nor in terms of the evidence hierarchy. So we've got, you know, again, RCT, we've got then a meta-analysis, then we've got a cohort, then another RCT. And I've got this sort of narrative paragraph summary as opposed to this sort of bulleted high yield. So just difference in the way that evidence is presented within UpToDate versus Dynamed. And then a last point is that, you know, whereas, as I mentioned in Dynamed, there's quite a substantial degree of editorial standardization. So the way that the information is presented and graded among the different entries or between entries will be really fairly standard. In UpToDate, I would say that the authors have a sort of greater leeway, or maybe that there's a lesser degree of editorial standardization. So this particular section of this entry, you know, does, you know, go into a fair bit of detail about the evidence, whereas some of the other either some of the other areas of this particular section, or, between in different entries entirely, other authors might choose not to go into detail and instead to just, present a handful of citations that if you want to read, if you want to know anything more about the study, like what type of study it is, you actually have to go out and look at the citation itself. So two differences there, beyond just sort of that up to date is leading with the, like, here are the criteria you might want to think of, also differences in the way that evidence is being presented. So I will pause for a moment there, and just kind of connecting it back to that last learning objective for us of thinking about when do we think each of these resources we're talking about today would be most helpful. I'd love to hear what anybody thinks. And again, there's really not a specific right answer, but I'd love to hear what anybody thinks about what might be a really helpful occasion to use Dynamed, or contrast if you think like, I would not want to use Dynamed for any of these reasons. And again, feel free to either unmute or pop it in the chat. Yeah, so when working on a research project, I think Dynamed could be a useful sort of first stop if you're getting your bearings on a topic. And it can also point you, a little bit more deeply into the literature. I think if you're working on a research project, almost always you will need to conduct a rigorous search of a database, like a primary literature database like PubMed, or Google Scholar, or multiple databases, depending on the nature of your research. But I definitely think Dynamed can be helpful as you're orienting yourself. I definitely think Dynamed can be great for journal club. Absolutely. Preparing for morning report, going in, I'm like interested to see that nobody actually picked B, because I think Dynamed personally, I think is very good for those like why questions. So if you're in a situation where it's like, okay, we early discharged that patient home on oral anticoagulants at morning report tomorrow. Like, why don't you tell us a little bit about the evidence for early discharge in patients with PE, or, that kind of thing. I think Dynamed can be really, really great for that, because you do get that overview of like, what are the studies on this topic? What are the types of studies? Again, how strong is the methodology? Some insight there. And quick lookup on the words. A couple of people have said quick lookup on the words, and it's always interesting to me when I teach sort of Dynamed and up to date, or Dynamed versus up to date. Some people are like, wow, I didn't know about Dynamed before. I really wish I had been using this all along, or I'm going to start using this more instead of up to date. Sometimes people really like about Dynamed that everything is in one entry, whereas, you saw with up to date, it was like PE, treat management and prognosis among adults, and then it would be like PE prognosis and treatment or diagnosis among non-hospitalized adults, or whatever it might be. They'll break out the topic into several different entries in up to date, whereas in Dynamed it's usually one very long entry. Can be sometimes people like that, other times people don't. But yeah, it's always interesting to me, because I think that well, anyway, I won't spoiler alert for the next slide, on which I'll ask you that same question about up to date. What are the occasions in which you think it would be either more helpful or less helpful? Yeah, I'm seeing a lot of like C's rolling into the chat. And I do think that that's one of the ways in which UpToDate really excels. I mean, apart from the fact that it's great for, like these kind of little like dosing lookup questions, the kind of thing that you might need to do like a gazillion times a day. I think it can be really helpful. Again, with Dynamed, it's like, here are the studies. And in this study, they use the Hestia criteria to determine risk. And in this study, they use the PESI criteria, or the modified PESI criteria, or whatever it is. In up to date, they're just kind of like, here are the criteria you might want to think about when you're making this decision in the moment. So I often think about it as like up to date can be really great for those like making a decision in the moment questions, and then Dynamed can be really great for the like why did we decide to do this diagnostic test, or what's the evidence for like why we thought it was appropriate to discharge that patient. home, early on those kinds of things. But again, I'm definitely not here to tell you like use Dynamed this way and use UpToDate that way. I'm here to just arm you, fill up that evidence toolkit so that you can sort of make your own informed decisions and test out some of the resources if indeed, some of the resources we're talking about today are either new to you or have just sort of slipped off your mental radar. So next thing I want to talk about a little bit is pre-appraised resources. And what I'm curious, like, what does the term pre-appraised raise in your mind? Does anybody want to say what they think a pre-appraised resource is? Either say like, I think a pre-appraised resource is this, or I think that, this insert resource name here is an example of a pre-appraised resource. Any thoughts that term might evoke?
I think what you have described on the slide is pretty accurate. Like it's those are the studies that are methodologically sound, clinically relevant, and those are the studies we would sort of read to get most information with the least effort.
Thank you. Any other thoughts? What about like a regular journal article, like an article that I might find in JAMA or the New England Journal or the Lancet or any other, any of other thousands of journals?
I think so. All of those, I mean, those are like peer reviewed. So there is an element of critical appraisal of like what was submitted to a journal, and they'll get, I think, reviewers that don't have a conflict of interest to like appraise that data. But like Sonal was saying, like systematic reviews and other studies that do meta-analyses or systematic reviews will collect all of the evidence that's already there if there are multiple articles, and will kind of explore for other things like bias in the methodology. And so they'll be able to give the reader that information, like what's the most sound evidence, what papers likely have bias. They'll try to combine results if possible, if the meta-analysis is possible.
Yeah.
And so you can trust that more than like an individual article.
Yeah, thank you. There's two, I think, really interesting things that you raised that I want to kind of call attention to. Number one is, in a pre-appraised resource, which is, the sort of filtered information that we're seeing up at the top category, what we're getting is, it's not usually a piece of original research, so an original clinical trial or an original cohort study, but someone else's critical appraisal, risk of bias assessment about how valid and reliable and externally generalizable the results of that study are. So that's, one point. And in a well-conducted systematic review, there should always be a risk of bias assessment. In clinical practice guidelines, usually if you look at the beginning of a clinical practice guideline, they will have like, here's how we're grading evidence in this guideline. And they'll say like, our criteria for grade A is a well-conducted randomized control trial, or a systematic review and meta-analysis. Our criteria for giving something a grade of B is a uncontrolled trial or randomized control trial with substantial flaws, or a cohort study. And then anything below that would be grade C. And if there's just expert opinion, maybe it's grade D, something like that. So that's what we could hope to find in a critical in a critically appraised topic, which Dynamed kind of sort of gives us with the Dynamed grade 2, so to speak. Although again, I wouldn't call it like a really rigorous critical appraisal. I would call that more like methodological highlights and lowlights. The other point that you raised that I think is a really important one is peer review. And I do think it's, very important to call out that like peer review and critical appraisal are not actually the same thing. And so it's weird because, for those of you who may have participated in the peer review process, journals have some guidelines and things like that, but it's not like getting a driver's license, right? It's not like you have to go through any kind of like training, or you have to show that you're capable in a certain way, or even that there is a really set standard that the entire peer reviewing community kind of closely adheres to. And so some peer reviewers, like when I'm asked to peer review a systematic review, I do basically just, my peer review process is to critically appraise it according to a critical appraisal checklist for systematic reviews, but that's not necessarily the case. And the other thing I want to call out about peer review is that there can be sort of competing interests for a journal, and sometimes journals like really have an incentive to be the journal that publishes a potentially practice-changing study. And because of that incentive, may publish studies that are like really high up for novelty, even if they have some methodological flaws, like even potentially very serious methodological flaws or conflicts of interest. And so I think it's really important for those clinical questions that are really central to your practice as a physician, or really, really have a lot of gravity and importance for an individual decision that you might make about caring for a patient, that on those occasions that you actually do maybe go through the process of critically appraising the study yourself, and like kind of kicking the tires on the study and using a critical appraisal checklist, and not even necessarily relying on somebody else's critical appraisal. Like I know, a primary care physician that I co-teach in the med school with a lot, he's like, yep, when the SPRINT study came out, I was going to really critically appraise that, both to have an understanding of how high quality is this evidence, because I'm talking about blood pressure medication and hypertension all the time, every day with my patients. It's really central to my practice as a doctor. And also because, looking at the exclusion criteria and who is eligible to participate in that trial could have a major bearing on whether I can apply it to, my patient population, for example, or whether certain patients I have, maybe, the results aren't as applicable to them. So I do think it's really important to be aware that peer review is important, but it's sort of like this very basic minimum in terms of, study quality, so to speak, and that there can be these competing priorities of novelty or whatever else it might be. So thank you so much for like contributing to that discussion, and it brought some really important points to light. So I want to take a look at 2 pre-appraised resources today. And the first one we're going to look at is the Cochrane database of systematic reviews. How am I doing on time? Ooh, oh my gosh. Okay. I'm doing okay. I'll take my New Yorker tendency to talk really fast and kick it into overgear. So we're going to look at the Cochrane database of systematic reviews, and then we will talk about a critically appraised individual article database or source called ACP Journal Club. So I want to just ever so briefly touch on why Cochrane is considered the gold standard in systematic reviews. You may have heard that, oh, Cochrane, it's the gold standard. Cochrane reviews are the gold standard. And I want to talk about why that is. First of all is unbiased authorship. So that also relates to a point that was mentioned about conflict of interest. Not necessarily conflict of interest, but a lot of times in a sort of non-Cochrane review, you'll have an author who may also very well be conducting original research on the topic. And so their previous studies may come into the scope of the systematic review. And it's just really hard and goes against our human nature to be unbiased and critical towards our own work. So very hard to, be both conducting original research and doing unbiased systematic reviews. Cochrane reviewers typically are not also conducting original research. So we've got unbiased review authorship there, really important. The next, and this is, I think, really the, the primary reason is because Cochrane reviews use a very well-defined and rigorous methodology, and they do kind of set the standard for systematic review methodology. So a couple of things really important that you can know about Cochrane reviews and then use to do like a sort of mini critical appraisal for yourself of any non-Cochrane reviews, because of course there's thousands and thousands of systematic reviews published in regular journals, not the Cochrane database. Number one, Cochrane reviews use an exhaustive search strategy. Typically, they will search 3 or more databases, often quite a bit more, like 7 or more databases, and use a really sort of thoughtful and comprehensive list of search terms to make sure they're turning over every stone and are not biased towards a certain geographic area or anything with the terminology that they're using. Second is that risk of bias is an absolutely fundamental hallmark in Cochrane reviews. And generally speaking, if you are reading a non-Cochrane review and it doesn't have a risk of bias assessment, you want to be a little bit skeptical there. What they say with systematic reviews is sort of like garbage in, garbage out. So like, okay, great, you found 8 studies, but if they're all, really shoddily conducted, or they have very small sample size, and you're not giving me a lot of information about that, then how can I be sure about the quality of the conclusions that you're drawing if I don't know anything about the quality of evidence? And lastly, in a Cochrane review, and this has sort of spread to many other systematic reviews, is that study selection, risk of bias assessment, and data extraction will all be conducted independently by 2 reviewers in order to minimize the risk of bias. So they're conducting these steps independently to in being guided by their pre-specified eligibility criteria. So these are all of the reasons why Cochrane reviews are held in such high regard. And again, you can kind of carry these points forward as you're doing a sort of mini critical appraisal of any non-Cochrane reviews you might come across to help answer questions. A couple additional benefits of Cochrane that I find can be really helpful. Number one is that every Cochrane review includes a plain language summary. It's really sort of designed, Cochrane is not meant to be a consumer health information source by any stretch, but because it's so famous and well regarded, they do include this for any consumers that might want to learn about their reviews. And it can be really, really helpful. One nurse educator I work with, he says, oh, I find that helpful in a my patient has what moment. So if he's like working outside his specialty area, or the patient has an unusual comorbidity or whatever it might be, those are occasions when, the plain language summary of Cochrane could be very helpful to you. The other thing is that they will say if there's insufficient evidence available to answer the question. So sometimes you'll see a Cochrane review that does this like rigorous, exhaustive search across, 7 different databases and thousands of results. And in the end, they will say, we've got insufficient evidence available to answer the question. One of the things that I find with sort of earlier career sort of learners and physicians is that like failure about like that fear about like that you can't prove a negative. Like, is there a trove of evidence out there that is eluding me because I'm just not searching effectively? So if you can find that Cochrane review that says there's insufficient evidence available, you can certainly rest assured that there's not a whole lot of evidence out there that is eluding you. So I want to briefly look together at Cochrane, and then also briefly touch on ACP Journal Club. So let's do it. So we've got the Cochrane database of systematic reviews, which is what we're looking for. We'll pop that open. And while that's opening, I'm sure it hasn't escaped your attention. Oh no, I'm sorry. I accidentally clicked on the Cochrane Handbook, Systematic Reviews of Interventions. I'm sure you may have all noticed that PubMed is not among the resources that we're going to be looking at together today. And of course, PubMed is a very, very valuable resource, but I would say there's very few occasions when PubMed would be my first stop for answering a clinical question. Almost always I'll want to go to a pre-appraised resource like ACP Journal Club or Cochrane Database, or a clinical evidence summary tool like UpToDate or Dynamed. Even if I need a primary study, I still would probably go to one of these resources to find that primary literature, and typically would use PubMed more for research projects, just because of the volume of literature, over 30 million citations. Even with a good search, it can be really hard to find what you're looking for if you don't have time to invest. So once again, I'm going to run my search for PE outpatient. And if I were to, run a search like this in PubMed, I'd be looking at thousands and thousands of results. You're going to see in the Cochrane database of reviews, I'm getting 9, right? So it's very easy to look in Cochrane and see, like, is there something here that's going to answer my question? And if not, like, no problem, I can very quickly move on. So we've got outpatient versus inpatient treatment for acute PE. Sounds pretty good. I will just scroll through the contents, jump down, for example, to the plain language summary that I wanted to call out, or that I did call out before, to get a sort of quick, and again, plain language-ish overview of the topic. And then I'll jump down to the methods to highlight some of the things that I was mentioning before. Go gadget Cochrane. Oh, okay, here we go. So again, we've got our really clearly pre-specified criteria, what types of studies are eligible, types of participants that are eligible, types of interventions that are eligible, what are the outcomes of interest. So everything's pre-specified. They're searching over half a dozen, well over half a dozen, approaching a dozen different resources. And you can see here that 2 authors independently screen results. 2 authors independently did data extraction, and then they will go on and talk about their approach to risk of bias that they subjected all of the eligible studies to. I do see it's 3:51, and I know that that's just about the time we're supposed to be wrapping up. So let me pause. First, I just want to pause and ask if anybody has burning questions I haven't talked about, because I want to make sure I leave time for your questions. Okay, I think I probably will skip the ACP Journal Club demo, just because I don't want to go beyond my time. I'm sure everybody needs a bio break before your next session. So I will send my slides and a link directly to ACP Journal Club as a follow-up to this. There's one more resource I want to call out, which is called Quick Medical Diagnosis and Treatment. I think it's a really, really great sort of summary and background. As I mentioned, today we spent most of the time talking about those occasions when you might need to dig further into the literature. But very, very often you don't need to do that at all. It's just sort of a background question, or, sort of just general considerations with this condition, or, DDX or whatever it might be. And the Quick Medical Diagnosis and Treatment resource, it's a resource available on the Access Medicine website. I find really, really helpful for that. This is a screenshot from the app version. So I will just throw that out there for anybody in case you're interested, because I think it's a helpful resource for those kind of quick questions, much faster than UpToDate or a textbook. And I will also share this tip sheet that I've put together. So I'll send that in the follow-up. And yeah, I know I'm about a couple minutes over, so I'll just pause one more time, see if there's any questions before we wrap up.
Thank you so much for that.
It's my pleasure. I certainly hope it was helpful. And if you have questions, you're welcome to reach out to me directly, whether it's, question about something we didn't get a chance to go over in detail today, or just sort of anything along the lines of searching and asking and inquiring. So thank you all for your time and attention this afternoon. Thank you, Chiefs, for having me. And wishing all of you the best of luck in your evidence seeking.